Hi, there he is, the man, the myth, the legend. How are you doing?
Good to see you, Marcos. So
Yeah,
glad you can do this. You've been awesome with all of our amazing speakers, and what a joy to be able to kind of go through and cherry pick the really hot stuff
yeah,
that catches both yours and my attention.
yeah. In the words of Donna Summer, hot, hot, hot stuff. So we want to start off by giving you a gift. Is that okay?
Oh, okay. I'm all right with
Okay.
that. What do
Word
we
on the
got?
st- word on the street is that you had a birthday, a very important birthday, and I made you a sign. I put
All right.
I put happy 90th minus 21 years birthday. Dr. Mark C. Scholz, you are the XY chromosome. Get it? Like you're the man. So you're an XY chromosome. It's you. You just had a birthday and happy birthday. I think you look incredibly well and you're definitely fit for your age. And I love it that you're wearing it proudly.
I had a delightful time. There's about 100 miles east of LA. There's a area called Palm Springs, which is a desert area. I know you've been there many times, and it's like summertime out there, even in December. And so Juliet and I go out and we watch tennis matches and go to dinner and slow down. And it was a great birthday this year.
That's awesome. But
Yeah.
before we celebrate your birthday present, I'm going to show everyone in the audience what kind of relationship it's like we're the odd couple. Here, I put Dr. Scholes. Only two simple questions correct, and you get free dinner for life every time I see you. All right? All right. The
These are
first
going to be
question,
tough questions, I'm sure.
what college football team won the most recent national title?
Yeah, I want to guess Michigan, even if it isn't true. So I'm going to guess Michigan.
Correct. One for one. You are this close to getting free dinner for life. Are you
All
excited?
right.
You should be. The chances
Oh,
that you get this next question right are zero, though, but I'm going to ask you anyway.
all
What
right.
team did they beat to win the national title? And I put some powerhouse examples: Alabama, Ohio State, USC, all powerhouse schools. And what team did Michigan beat in the final game to win the national title?
So what
Free
are my
dinner for
choices?
life.
What are my choices? Ohio, USC, and what?
I said Ohio State, USC, Alabama are just three powerhouses. It could be those three. It could be someone else.
Oh, okay,
I'm just trying
okay.
to show the audience how you don't care about my hobbies.
So that's misdirection then. All right.
Maybe or
Well,
maybe not.
I'd probably know if it was USC since I'm my daughter was a fourth generation USC alum. I have absolutely no idea. And I think it was Ohio I would have heard about it because you guys are really strong competitors, right? So I'll go with Alabama.
Sorry. Thanks for playing though. In fact, you know what? I have designed something for your birthday if you don't mind. Are you ready for this? Your first question was right. Your second one, all right? Your second one gets this. Are you ready? Sorry, that means you got it wrong. So the answer is Washington. So you
Oh,
unfortunately you don't get dinner for life from me. And I proved to the audience that all this guy does is prostate cancer and tennis, and he really doesn't follow football, which is incredible how we became friends. I just don't know. But all right, you ready for your birthday present? Let's bring it
uh,
out. Bring out his birthday present. Happy birthday to you.
all
Happy
right. What do we got?
birthday to you. Oh, you're going to love this. This is probably the best birthday present we all came up with. Look at that. Look
Uh-huh.
at that. It's a prescription mug of tennis. Read it. See, it has your name on it, right? Read it. Read what the prescription says.
Play for 2 hours as needed until your mood improves. It may cause happiness, laughter, and unexpected brilliance.
Yes.
And then refill when empty.
And it says for best results, take with friends. Discontinue use if tantrums arise.
Well, this is very timely. This is like my first cup of coffee in probably a year.
But we'll come back to this point. But the reason the cup was so important is that we constantly stress during the Q&A that physical activity and exercise is great to make you feel just physically better. but it really should be prescribed for mental health. It's such an incredible mental health booster, reducing the risk of depression, anxiety, stress, helping cope. Memory loss. It's incredible it should be a prescription with every single drug treatment. Before we did the Q&A this morning, I said, I'm just going to be on the top of my game. I went running for a little bit more than 6 miles. I'm at the top of my game and I'm feeling good. You're in trouble, baby. All right. Are you ready?
I'm ready. Let's jump in.
All right. Let's talk genetics first. I want to get your just overall thoughts on the genetics lecture and just, what comes to mind when you think of the genetics lecture? Go.
What comes to mind for me is the struggle that I have in communicating with patients so that they can have a sense of proportion in the decisions that they make. The talk was beautiful. It was very easy to understand, even though these are fairly challenging concepts, and I enjoyed it a lot, actually. And when you have a talk like that, it allows you to sort of summarize it in its entirety. It had a very cohesive, he talked primarily about the germline type genetic testing. The germline DNA is very relevant in trying to decide if you have, if your children might catch prostate cancer. If you have prostate cancer, are your children more likely? And he went through that in detail, pointed out that yes, indeed. And as you get more and more people in the family with prostate cancer, your chances, if you're in that family, go up. I respectfully disagree, though, in practical terms, with the conclusion that if someone is at higher risk, that we're going to start testing at a younger age, PSA screening, looking for cancer. It sounds kind of logical on the surface, but in practicality, it's so easy to screen for prostate cancer. If we want to catch it, why wouldn't we screen everyone? Having a favorable genetic profile doesn't guarantee you that you won't catch prostate cancer at an early age. It only means that it's less likely. Less likely is not good enough. I think that if people have the resources and the time, and of course there are problems with screening that we've all heard about, where people get sucked up into the system and get an unnecessary radical prostatectomy, which is a real
or radiation treatment, or radiation,
or any kind of fear mongering, even active surveillance. You get diagnosed with a low-grade cancer,
yes,
and you do the right thing and you watch it. There's a lot of anxiety associated with that. So my point is this is a common statistical error, I think, that's made, and we've talked about this a little bit in screening for heart disease. When you if someone says there's a 2% chance of having, let's say a 65-year-old gets one of these heart scans, there's a 2% chance he's going to have a heart attack in the next 10 years. We pat him on the back, say, that's wonderful. You're much better than average. And if someone gets a heart scan and they've got a lot of plaque, we tell them there's a 15% chance you're going to have a heart attack in the next 10 years. And we say, oh, you better take precautions. The trouble is that a 2% risk of something, although it is low, if you're in the 2%, it's 100% for you. You still had a heart attack, and it might have been preventable if you'd taken appropriate precautions. So I think that even though we can show the family history with, germline genetic screening and looking at family history and all these factors, we can tell people you have less risk, you have more risk, but I don't think it argues for changing our screening patterns. I think everyone should be screened, even when they're supposedly at less or lower risk of catching it, because there are still people who catch it. And of course, we want to catch those rare individuals at an early stage, just as we would want to catch the people that are more likely to get it at an early stage.
I see what you're saying. I'm going to bring up some situations where it's a little different from screening, but you just made me think of one of the biggest controversies going on right now is, and again, this is somatic testing. Part of the reason we had a germline testing lecture was that no one has ever tackled that by itself. Mm-hmm. And so we just decided, we want to be the first to do a lot of things that we think are appropriate. We get so many requests that, can someone just tackle this subject? And here's someone who basically works in it full time. But it makes me think of, when you talk about screening, and it's a relevant point, what's hot right now are doing liquid biopsies earlier and earlier. So now there are all these commercial tests that people want to find out by doing a liquid biopsy, whether or not they have any free-floating DNA out there that might suggest they have a tumor, right? So everybody's talking about, hey, finding it earlier and earlier with these tests, but that has its own set of issues. I don't know if you want to comment on it before I comment on it.
Yes, that is, I think, very relevant to this argument, is that if we have a potential window into catching what would be a rare occurrence, catching a pancreas cancer, a lung cancer, a bone cancer, a brain cancer at an early enough stage to cure it, which is not usually the case. Usually these tumors, we don't have a PSA-like blood test as for these other tumors. And so they show up when someone says, hey, this hurts. And it's a metastatic spot, and the disease is no longer curable. So PSA, because it gave us that early window, changed the landscape, and now we don't think of prostate cancer as being anywhere as nearly as dangerous as those other cancers that I just listed.
Yeah.
So now that we have these cell-free DNA tests where they can look if in your bloodstream for very tiny amounts of cancer-related DNA, will that be the onset of a PSA-like test for these other very scary cancers? And there's no doubt that the technology is able to, in certain instances, catch these other more rare, they're not rare tumors, but catch them at an early enough stage where they may be curable. As you know, there's going to be all the same problems that we had with early PSA testing, where once these cancers were discovered, it wasn't realized that at least half of them, half the prostate cancers, were of a harmless variant that never spreads. And one of your speakers pointed out that over 1 million men have had unnecessary surgery and/or radiation. The people that were saved were blessed, and we're very grateful for that. The people that got unnecessary treatment were cursed by it. So that is also a risk with these new cell-free DNA tests, because if you find something, then finding the actual tumor when it's small may be difficult. Could it create a lot of unnecessary anxiety? Could it create a lot of unnecessary scanning and biopsying? And yes, it could do all of those things. So it took us 30 plus years to figure out how to balance out the PSA confusion and start to get a sense of what's going on. And the industry is still charging along with, 10, 15 years out of date, and they're still doing surgery and radiation on people that don't need it. It's still happening, sadly. So with that caveat, and I'm sorry to wax so long on this, but
but it's an important point. It's one of the most common questions I get from just out there in the sphere. My doctor brought up this liquid biopsy test. I don't have cancer. Should I get it? And I always say, look, you're going to hear plenty of pros, but now let me tell you about the cons. That's my job, right? And you identified one of them. And another one that should be identified is in the early preliminary testing of these things, they're very good at identifying later stage disease. They're more questionable right now in terms of early stage, in terms of their track record. Second of all, they haven't been proven yet to reduce cancer-related mortality. Now, that may come, but I don't know if I want to be the guinea pig for that. And then third, what no one ever talks about is, when I used to get hired, people wanted to hire me away from Michigan to run clinics. They would hire me to say, hey, wouldn't it be great if you were the president or CEO or the person that led this full body scan clinic? And I'm like, what do you mean full body scan? Where you're perfectly healthy. Remember all these scans? And we're going to do a full body scan on you, whether it's an MRI or CT or whatnot, and we're going to find cancer early. Remember all the hubbub about that 10, 15 years ago?
Well, wait. You preempted me. That's where I wanted to go next with this discussion. Yes, 15, 20 years ago, they used CAT scans. And they were pretty much abandoned except for one purpose, and that being to check for plaque on your coronary arteries. That was the good part.
Yeah.
The rest was they were finding all kinds of distals and shadows and spots, leading to all kinds of consternation, and almost never turned out to be actionable cancer. What I was going to ask you is that
Yes.
There's a new wave now of using high field strength MRI in exactly the same role as it was for total body CT scans. So we know that total body CT scan was a bust. Those companies all went bankrupt and they're not around anymore. But there's a resurgence in total body MRIs. And I've given this some thought, but I want to hear your thoughts first.
No, my thought is, okay, so now we don't give you radiation, but my thought of all these screening tests are the same. I think we share that philosophy is you better dang, notice I use the word dang. I'm not going to use any bad language. Dang. You better dang well know the pros and cons of what you're getting into before you get into it. I want to use me as an example. I'm in my 40s. I got lots of connections. I got a friend who owns a full body scan place in one state I'm not going to mention. He says, I'll give you one for free. It was an MRI, by the way. And the reason I did the scan was because we have a lot of people who have died young in my family. I have one person in particular that I look like that died of an aneurysm, a berry aneurysm. And so anyway, he said, I can take a look at your brain, see how it's functioning. Of course, it's going to come out to be stellar. It's a very pretty brain. So I go in there, not thinking about the pros and cons, because I want to see what's going on in my brain. So my brain, takes a look and says he's going to look at the rest of the body for free because I'm a friend. All right, no problem. I sit down with the radiologist. Long story short, he goes, Circle of Willis, everything's looking really good. I went, best day of my life. I've been waiting for this.
But that's techno speak. So no berry aneurysm.
Right. Nothing going on in the brain right now you should be concerned about. But then he goes, well, we looked at the rest of your body. You've got a lot of cysts on your liver and kidneys, a lot for your age. And all I remember is walking out of there. Here, I just wanted to hear about my brain. All I have done is, instead of being joyous for the next year, I walked out going, oh my gosh, I got all these cysts. Oh my gosh, I got to have these looked at. I completely got way too much information. It made me so anxiety prone. And I use that as an example of be careful what you sign up for until they show data. Because if they're not showing data that they improve your life, you've just become one of the guinea pigs for that data. So that's my worry. That's my worry.
So this expands to this whole idea of genetic testing too. Because the chances that the genetic testing is going to move the needle powerfully, and we're talking about germline testing. I'd say the strongest argument for doing germline genetic testing is if you want to pass on some information to your children that might be actionable. That I suppose is a pretty solid motive. We've got BRCA in our family, not me personally, but let's say I did. I would definitely want my daughter and my son to know that. So that's a strong argument for that. But the exact same thing can happen. They can give you a long list of weird mutations that you have, and you have no idea what the implications are. Or sometimes you know what the implications are, but there isn't a dang thing you can do about it. I use that word dang again out of respect for you.
It's very contagious, that word. It's very contagious. But I think this is part of the mantra, the thinking into where part of prostate cancer got overdiagnosed. That's what you're saying. We have a test. Anytime it shows some volume, it shows that it's moving toward a high area, then we need to be biopsied, right? And we realize now it comes with catches. Just to rely on that to be biopsied, just to rely on that to discern whether or not you have significant or non-significant prostate cancer. So I'll tell you during the Q&A where the most controversy was with germline. And I don't know your opinion, but I know darn well what my opinion is evolving toward. I think we're germline testing. And again, for the audience, the sign that I held up all the time, that's what you were born with from day one. Somatic tests is the tumor. All right. Here's where I wish there was more discussion. Are you ready for this?
Ready.
Active surveillance. Okay. Now, give me the stage for a second. We know that family history is a pretty wimpy predictor of whether or not you're going to come up with one of these mutations that's serious. We used to think it was a good predictor, and now there's a new study called the IMPACT study, where almost 70% of the positive men for BRCA didn't have the family history that would qualify them to necessarily look at BRCA. Okay. So now you have all this list of criteria that you have, Klotz has, for active surveillance. You got to follow this. You got to do this with PSA density. You got to do the MRIs. But we also know preliminarily, again, I'm going to focus on preliminarily, that if you come up BRCA positive as an active surveillance patient, the chances that you may have to move on to treatment or may progress to a more aggressive disease right now in the data is significantly higher. So I'm going to play angels and devil's advocate. Why not offer everyone who's considering active surveillance a germline test? Why? I'm not saying you have to have it. Why not at least have it come up in the discussion?
Well, I think the reason is, and this expands to other types of genetic testing in this setting as well. So the whole world of active surveillance historically has been embraced rather reluctantly. The idea of watching cancer is very counterintuitive. So they were able to demonstrate that it's safe to do active surveillance, 10, 15 plus years ago with no MRIs, no PET scans, and tremendous ignorance about how prostate cancer behaves because we've learned so much more in 15 years. And they showed with those crappy tools that you can safely do active surveillance. Now, does that mean that the industry embraced it? No. It's so counterintuitive to watch cancer that
Absolutely.
I'd say we're lucky now if half the men that are eligible for active surveillance actually get it, even today. Do I need a new test to scare people out of active surveillance just because they show that we can refine the likelihood that you're going to go off active surveillance at some time in the future? That's true. I don't deny that. You can refine that analysis, but that's not the analysis. Let's say that you are a 65-year-old guy and you're projecting everything looks hunky-dory, and we say you've got a 10% chance that you'll have to go off active surveillance in the next 10 years. And then we get a BRCA positive, and we say, oh, now your risk is 30% chance that you're going to have to go off active surveillance in the next 10 years. I don't know why people all of a sudden jump and say, well, that means I can't do active surveillance. We already know from vast experience that if you surveil people closely and act at the time that you're supposed to take action, that your cure rates are the same as if you got treated the first day you were diagnosed. So active surveillance is such a safe methodology. I don't think it matters whether you're BRCA positive or negative as you embark down that pathway, as long as you follow stringent surveillance techniques. Now, all that being said, would I deny someone that wants to know what their genetic status is? Absolutely not. And there may be some very risk-adverse people who would like to, who are extremely uncomfortable with the idea of active surveillance and need an argument to not do it.
Let me bring up something that you know, but we never talk about. I understand what you're saying. Sometimes too much information is not healthy. I understand that. We agree. It's like the body scans. It's like, where are we going? Don't you find it interesting, though? Don't you find it incredible? Because my family has had so much breast cancer that today, if a woman is BRCA positive, strongly BRCA2 or 1, that they'll do prophylactic mastectomy. Some people will have their ovaries removed. They just don't want the excess risk. When's the last time that you heard of a man becoming BRCA positive and saying, I don't want my prostate, I want it to be taken care of, I don't want this risk because so many people in my family have died of prostate cancer? And you've met these patients where they're just riddled with prostate cancer in the family, early deaths. I know you have. I've met these people. And I'm just saying, don't you find it interesting that in breast cancer, you're being proactive if this comes up positive, for getting the test and then doing something about it? Yet in prostate, crickets, man, crickets. And that's the part that
well, the thing is, I'm not sure I agree. I'm not a breast cancer expert, but but remember, most prostate cancer patients are my age, and if I can live another 15 years, I'll say I lived a full and happy life. Do I want to spend the next 15 years impotent and incontinent? I don't want to roll the dice unless I know that it's going to prolong my life very significantly. My life's not going to be that prolonged anyway. I think the bottom line of our conversation is that you ought to know your own psychology a little bit before you go into all this prognostic testing. I was confronted by a patient that you and I both know about whether he should get a total body MRI. And so I went home and thought about it. So I always start off by thinking, well, would I do it? And the analogy that I did, I said, well, let's say I had an MRI in my backyard that I could use it every day if I wanted, and it cost me nothing. Because these total body MRIs, they're charging like $7,000 for these things. Let's say it was for free and I had it in my backyard. Would I crawl into that MRI once a year just to make sure I'm not missing anything? And I thought, well, I'm not a very excitable guy. I can live with ambiguity. I can live with risk. I used to play poker and I was pretty good at it, incredibly sophisticated in terms of the relevance of all these different ramifications of reading scans and their limitations and whatnot. So all that being given with the right psychology, the right background training, the answer is if it was totally free, I probably would crawl into the MRI once a year and get the scan. For $7,000 a year, even though I've got $7,000, I don't think I'm going to do it. But but I'm not necessarily a typical person. Now, the patient that you and I both know, you may or not even know who I'm talking about as we speak. I'm going to tell him to be a little bit careful in terms of possibly ruining his quality of life for a very, 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 very tiny incremental improvement in saving his life from some unknown cancer.
And that's fair. I think the argument comes down to, I just want people to have the objective information of what they're getting into, because
they need to do their background work first.
Because a lot of people will automatically always lead with testosterone. They'll go, oh, I can handle it. That's not a problem. And then you talk to them a year later, they're going, what do I do? Oh my gosh. It's like, I give the example of what I went through. I didn't really consider what else they'd be looking at and what else they might find. And I almost became obsessed for a year of what is happening to me. I'm falling apart.
I know you well enough, Mark. You should have called me first. And I would have said, Mark, you do not have the right profile, the psychological profile for this type of stuff.
I know, but it was free. I didn't have to pay. By the way, this is napkins. My son gave me
this segues very nicely into what Dr. Raymond was talking about with all his imaging of the prostate. You know what is exactly the same issue is what we call the random needle biopsy of the prostate. Now with the imaging, we can see where these little shadows are and we can target them. But the policy has been, well, let's just look at the rest of the gland with all these needle sticks randomly and let's see what we find. And gosh, what do they find? They find all the little specks of something called cancer. Now, if you read the bottom line, it says, by the way, this never, ever, ever metastasized. Ooh, but it's cancer. It's cancer.
Yeah.
And these random biopsies have been the root cause. Now, they were necessary up to about 2015. The MRIs weren't good enough, and we had to live with that ambiguity of random biopsies. Now, it's been clearly demonstrated that people who do random biopsies are uninformed. They either that or they don't have access to good MRI imaging.
I asked Raymond, and in full disclosure, this Dr. Scholz brought Dr. Raymond, and I'd heard his name, but he's probably the one doc out there I haven't met at a meeting. And maybe he said hi. He blew me away how good he was overall. I was just really impressed. But yeah, I mean, the idea that what I brought up with him in the Q&A was really educational. I said, well, forget prostate for a second. I know you've dabbled in liver and kidney. What's going on? He said, I'll tell you what's going on. Do you remember liver biopsies? I said, yeah. He goes, we don't even do them anymore. The MRI picks it up. We don't even have to do a biopsy. I said, you're not doing them anymore, or hardly at all? He goes, not at all. I said, do you remember 10, 20 years ago, you would just fear the idea of getting a liver biopsy? He said, yeah, we're not even doing them. MRIs evolved to such a point where what we see is what we see. And I said, do you think we're going to get there with prostate cancer? And he wasn't willing to hedge, but it's a great example.
Well, let me jump in right there, because he also mentioned PET scans.
Yeah.
And we are seeing patients, again, some who have more money than they know what to do with, who get a screening MRI. They're slowly their PSA's up a little bit. They're savvy enough. They go get an MRI. And then they there's a small little shadow, maybe a PIRADS 3, PIRADS 4 lesion. PIRADS 4 means that it could be something consequential. And then we we say you've got two choices. You've got financial resources. You can go ahead with your targeted biopsy, which is the traditional approach, or why not get a PSMA PET scan because it's disease specific. It only lights up with prostate cancer. If this little shadow doesn't light up, 90% likely it's not prostate cancer, and we can keep watching it, make sure it doesn't grow or something. But if the PET scan's clear, probably don't need a biopsy. So yes, I think in some ways we are getting close to what's going on in liver cancer.
Yeah, that's just really unbelievable, isn't it? So yeah. I tried to bring up, I guess we're talking about Raymond now, right? So we've moved on.
Yeah.
I
didn't have it. Let me see if there was anything else. I mean,
there's one other thing I'd like to bring up on genetics that wasn't brought up in the talk, and it's pretty critical. Are you ready for this?
I'm ready.
You could quiz 1 million people in healthcare, and I bet you they wouldn't. And look, I have to educate myself. And this is the beauty of PCRI. We realize information is coming so quickly that you need other people to accumulate it and go through it and then disseminate it. That it's just one person keeping up with it is too daunting. This is not, my wife remembers 25 years ago for family dinners, after dinner, we'd go to the library, the medical library, and photocopy all the journals. I mean, that was 25 years ago. And now if you go photocopy a journal, something's wrong with you. You can get it all online. Yep. So I thought this was really important. And I hope that Alex also highlights this in the Q&A. It's called GINA. So GINA is the Genetic Information Non-Discrimination Act. It kicked in on November 21st, 2009. So it protects you from genetic discrimination from health insurers and employers. And that's the good news. So if you end up getting a germline test, the good news is that you're protected, that they can't hold this against you. The bad news is, again, because my job is to play devil's and angel's advocate, is it does not cover life, disability, or long-term care insurance. So the catch with GINA is that if you're going to discuss a BRCA or anything else in the family, they have to know that if something comes up and they're a big fan of life, disability, or long-term care, theoretically, you're not protected there. You're protected generally from your employer and your own health insurance. I didn't know any of this until recently because I thought we would cover it in the talk and we didn't have time. But to me, this was one of the most important concepts to bring up when you start doing germline testing. You are protected in some ways. Other ways you cannot be protected. So this is part of just being careful when deciding when you want family members to start running out and getting tested.
Well, this is very practical also for men that have a high PSA and are considering a random versus a targeted biopsy.
Yes.
So I can't tell you how many letters I've written on behalf of patients to insurance companies in men that had a random biopsy and they're on active surveillance and they've got 3+3, everything's perfectly fine. Statistics show that prostate cancer mortality rates are lower in men with 3+3 than the general population, and it's obvious why, because they're under close surveillance. And the insurance companies, however, see the word cancer, and these patients can't get life insurance or sometimes certain desirable types of health insurance. So we write a letter with no expectations. The insurance company can do anything they darn well please. If they want to take this cancer diagnosis at face value and say this guy's uninsurable, that's their prerogative. And so this is a very practical, real issue that we see on a day-to-day basis in my practice.
Yeah, something to think about. I would have never thought of, like, I'm just going back. People want my opinion. I'm a big fan of just discussing the idea of germline testing in some situations, but yikes, I don't want some family member getting tested who wants to buy a bunch of life insurance, and then it's going to be held against them. So I want to bring up one more thing with genetics that I also brought up in the Q&A. And you and I can talk about this in the fall conference, other places. But, there are these other conditions that people think are absolutely rare, but they're not really rare when you look at the population. So something that we don't often talk about in prostate is Lynch syndrome. And Lynch syndrome is often, it used to be attributed to basically a high risk of early colon cancer. In fact, the old name was hereditary non-polyposis colon cancer. And the idea was that you would get a colon cancer, possibly aggressive, at an early age in these families, and a lot of them didn't necessarily start with polyps. Turned out that's wrong. I mean, some of them actually do. But now that they've looked at Lynch syndrome, they found that it's associated with a lot of other potential cancers out there, not just colon. And prostate may be one of them. And I looked at the number, it's 1 out of every 300 people carry one of these mutations. The other thing I want to say about it is, even though it's called Lynch syndrome, named after Henry Lynch used the data from a University of Michigan doctor called Dr. Aldred Warthen. And he had a seamstress called Pauline Gross. And Pauline Gross came to this Michigan doctor in Ann Arbor and said, I'm not going to live. By the way, I'm your seamstress. I'm not going to live a very long life. And the doctor said, why do you say that? And she said, all these people in my family have died young of cancer. Now, this is going back to the 1800s, early 1900s. And he said, like, how many people? So he ended up doing all this genetics and realizing that these were all connected. And then Lynch came along, looked at that data, and is attributed with the name Lynch syndrome. But reality, it should be called Warthen syndrome, or it should be named after Pauline Gross. And so that's an unsung hero in medicine. Anyway, so Lynch, have you had Lynch syndrome patients? Because they can come up positive in a germline test and have a higher risk of prostate cancer, or is it just something that you haven't dealt with?
Now we're talking about, we spent most of our time talking about the use of germline testing in early stage, but germline testing in advanced stage, boy, we scored the lottery. It turns out that Lynch syndrome patients who have prostate cancer, I have one in fact, respond incredibly well to immune therapy, and that is such a joy, because the modern immune treatments, and there is a test now to ensure that you're at low risk for immune toxicity as well. But immune therapy can be a far less toxic and a far more effective way to handle advanced prostate cancer. And in someone who has metastatic prostate cancer, it makes all the sense in the world to get both your somatic and your germline testing to make sure you could score the lottery. If you came up with a Lynch syndrome, that puts another arrow in the quiver, and it's a big, powerful arrow.
I think it's so interesting that all these guidelines, NCCN guidelines and all this, they say if you meet these criteria, you should get genetic testing. And then it gives you a range of the genetic tests that you should have tested. In there are actually the genetic mutations for Lynch syndrome. So yep. It's a really fascinating syndrome. Do you know how many people I looked up? This could be wrong. I saw it in one database. Do you know how many people with Lynch syndrome know they have Lynch syndrome? It's like 5%, like 5 or 10%. Can you believe this? But you just bring up a really good point. In advanced disease, that could be a lottery win. So you test for that, and you have a patient with Lynch syndrome that responded to immune therapy. Oh my gosh, you made my day. Now I'm going to make your day further. Everybody talks about Lynch syndrome, 1 out of 300 people. Oh my gosh, it's everywhere. It's everywhere. Do you know what occurs in 1 in every 250 people? Familial hypercholesterolemia. Isn't that incredible? This goes back to our mantra. Everybody talks about the cancer mutations, but the reality is the cholesterol. This is a mutation where when you're very young, your bad cholesterol just goes through the roof, and people die of heart attacks in their 20s and 30s. They have LDL cholesterols of 300, 350, but this is actually more common than any other syndrome, have a genetic predisposition to carrying a very high cholesterol. So I just had to balance that. Anyway.
And of course, it's, you don't even need a genetic test to know that you're a risk, because
that's right.
As you and I many times have said, not only do you want to check your PSA, but you want to check your LDL cholesterol.
That's right.
Know your number.
Know your number. 90% of people with this genetic condition, 90% have no idea that they have it.
No.
Man, I feel like we're conquering just huge mountains today. We've climbed Everest a few times. Now we're ready to stick with Raymond and just talk.
I want to throw out a deep and heartfelt thanks to Dr. Raymond for his subliminal presentation of sharks and minnows. So I searched through my vast collection of ties. I couldn't find any aquatic type ties. The best I could do was a little fish here somehow got onto this tie, but that powerful idea, which he didn't belabor his rationale for why he's doing that. What he's saying, of course, is that that if you don't specify the subtype. Let's say you just say there's fish out there.
Yes.
Well, fish, we eat fish. There's nothing to be worried about. I'm going to jump in the water and swim. Oh, I'm sorry, it's a shark. Yeah, I should have told you it was a shark. I just said it was a fish. And so that lack of specificity about the type of fish, and I don't even know if sharks technically are fish or not, but you get the idea that when we talk about prostate cancer, everyone sort of registers it like it's a fish. And we know what cancer does. The whole idea of sharks and minnows, he kept coming back to that.
Yeah.
Was it minnows? Yeah.
Yes,
I mean,
it was minnows.
Yeah. So the statistics that he shared, I thought were very telling. So he says that 15% of us guys are going to get prostate cancer at some time in our lives. That's 1 in 7. These are easy numbers to remember. And of the people that get it, 15% metastasize. Again, 1 in 7.
Yeah.
So that's 1 in 49 of us guys that are going to get metastatic prostate cancer someday. It's 1 in 7 of us that are going to catch prostate cancer. So the idea of sharks and minnows is a powerful way to start thinking that what was called prostate cancer, when you were told you had prostate cancer, that's not enough information. It really tells you nothing. You have to know what type it is, and that extreme of something that metastasizes and doesn't metastasize is as different than a shark is from a minnow.
Yeah, it was really good. I had a shark minnow sign, and it's driving me a little batty that I can't find it. But what I said to him during the Q&A, and he got it wrong, I think you're going to get it wrong too, is I said, all right, sharks versus minnows. I said one of the most famous movie lines of all times is that you're going to need a bigger boat. Where's that from? And
well, if I hadn't seen the very first part of your Q&A, I never would have guessed that. What was the name of the shark movie that was eating people? I can't remember now.
Jaws, 1975.
Jaws, yeah.
Roy Scheider said it. His name, he was Captain Brody, as that was his tagline. And he sees the shark. He goes, "You're going to need a bigger boat." But it was really good the way he brought it up, sharks versus minnows, because people, I haven't heard that analogy.
So normally I don't like statistics, but I love that 15% of us get it. Of those who get it, 15% metastasize. And that's the real cancer, the one that spreads. That's the real one we have to take seriously. And
Yes.
We'll go into how seriously, because Dr. Kwon got into that very nicely as well. The other statistic, this was kind of a cool one that Dr. Raymond shared. He said 70% of men who have a screening PSA above 4, which is the supposed golden threshold of when you start looking for cancer,
Okay.
will never, ever, ever, ever be diagnosed with prostate cancer. 70% of men that have a PSA above 4 will never in their lifetime be diagnosed with prostate cancer. So you say, that's terrible. Why do we use PSA? We use it for the 30% who do have the cancer, so we can scrutinize them more closely and find out if they have a shark or a minnow.
Yeah.
Yeah.
Well, that's a good point.
Yeah.
Yeah.
I thought that was really nice stuff. So no more statistics beyond those.
I thought my discussion with him on when he feels comfortable using gadolinium or not was really good too. I mean, people should go back and watch that, because at the end of the day, gadolinium is such a polarizing word for some people. And he really broke it down. He said, look, we've learned when we have to use it, ideally, and when we don't, and he breaks that down in the video. I won't go back through that. So I think he did a really good job with that too. Do you want to talk about PET-CT a little bit?
We can. Let's, he has, the UCLA department does a really beautiful job getting quality prostate MRIs. And it takes, he pointed out in his talk that they may be able to transfer that wonderful information and knowledge that they've gleaned there through a lot of experience into artificial intelligence, which would be fabulous. Because one of the problems that we see, as big a fan I am for imaging as a substitute for random biopsy, MRI imaging as a substitute, is that the the experience in the general community reading these MRIs is limited, and there can be real problems and many false interpretations.
Yes.
So why do I keep recommending MRI when people could get terribly misled by someone that doesn't have enough experience to be reading them? You can always get it double checked. I send a lot. You can get the images on a disc, and I send a lot of these to UCLA for a second read, and they do two things. One, they look at the image quality. They make sure that the pictures are even good enough to interpret. Usually they are. Sometimes they're not. And then, assuming they are of high enough quality to be interpreted, then you have someone that's looking at hundreds of these every month who's been deeply trained, has tremendous experience, and then you get a very confident readout as to whether there's anything there that needs action. I can't tell you how many times I've had patients who've had MRIs at unknown facilities around where it sounds like they're going to die. There's a big, problem here and there, and overread, nothing. It's problem free. So it really behooves people to do two things. One, if someone says your PSA is up, get an MRI, and then if the MRI comes back favorable, I don't tend to be as suspicious, because these less experienced doctors tend to overread to cover their assets, to make sure that they didn't miss something. And so they read stuff into these MRIs that really isn't there. But if your MRI comes back and it in the reporting format looks professional and they say we don't see anything, overreads on that almost always are going to be confirmed that there's really nothing there, and that you can forego an immediate biopsy. Now, does that mean you can forget about it for the rest of your life? No. MRIs can miss 10% of small cancers, and because prostate cancer is slow growing, and if it were to grow over the ensuing year, it's not going to spread in that first year unless it's some freaky, unusual exception to the rule. And if it's a little bigger the following year, they'll compare the clear old scan with a new scan and look for any changes. And if they detect something a year later, you can have a targeted biopsy and still diagnose the cancer when it's curable and localized.
Yeah, no, I mean, that's a good point. I tried to show them the catch with MRI. You just mentioned it, and that number varies depending on the study, but it goes as high as, I probably brought it up, maybe I felt like it was 100 times. Why don't you advertise that you do second opinions on MRI readings? He said, we probably should. I'm going, of course you should. All of you shouldn't be shy. Just advertise it, because the average person in my hometown or somewhere else out east or south, they don't know that I can go send it. I mean, you're right there, but they don't realize that's an option. They think about that now with pathology. We've won that war, right? A second pathologist, no problem. Yep. A second MRI reading. It's so funny. That's kind of how we ended. And he's kind of laughed. And I said, I'm serious. You guys need to change the website. So I'm glad you brought that up. Yep. I also tried to trip him a little bit with, okay, MRI is great, and it is, but it can miss up to 20% of clinically significant prostate cancers. And he reminded me of something which you and I have talked about, which doesn't get a lot of attention. So I'm going to be Mr. MRI here for a second. Those 20% that are missed, maybe even 10, 15% of those have in general, when they test those and they go find those later in a study, they have very favorable characteristics. Yep. So, right? So what this is sold at is MRI misses up to 20%. You go, oh my gosh, what if I'm on that 20%? This is a bad shark. No, what he's saying is that a vast majority of the ones they missed look so similar to normal prostate tissue that they act like normal prostate tissue. Ergo, they are minnows in general, not sharks. That should increase your confidence when it comes to MRI. It shouldn't decrease your confidence.
Yes. Yes, and we know that this, with random biopsies, the threshold for going off active surveillance historically has been after you jab needles all over the place. If you find a millimeter speck of something higher grade, get that prostate out or radiate that man today. That policy we know is now. Why are we doing that? It's because the doctors don't want to have a single case on their record of anything untoward happening, and they're willing to treat 1,000 people unnecessarily to save that one guy. And these small amounts of slightly higher grade cancer are in most cases going to behave very benignly. How do we know that? I've been seeing men come into my practice over the last 30 years, didn't check their PSA, and finally 5, 10 years after the last time they checked, their PSA is 75. And we get a scan on them, and there's a big goomba of a cancer that you can feel with your finger.
Huh.
And you get one of these newfangled PSMA PET scans, no metastasis. So prostate cancer has, in general, low metastatic potential. In waiting a year for someone that had an invisible cancer to go to a visible cancer, those guys are 5 to 15 years ahead of the guy that comes in with a spot you can feel with your finger.
Yeah.
That's a gross degree of very advanced cancer. The idea that every little speck of higher grade cancer, even though it's invisible on an MRI, needs immediate treatment, well, we know now is wrong. More and more men are embarking upon active surveillance with 3+4. So there's a little bit of high grade disease there. And small amounts, we know, also have low metastatic potential.
Yeah. I mean, so it really is a great advertisement for that test. It really has.
Let's go on and talk, as you mentioned, about PSMA. I already mentioned one new role, and that is a substitute for biopsy. It's an expensive substitute because insurance companies won't pay for it if people don't have a pre-existing diagnosis. But there's another role where insurance companies, especially Medicare, does pay for it, and that is in these men that have proven low-grade prostate cancer, they're 3+3, but their PSAs are running high. The so-called PSA density is elevated, and this is a very common scenario in my practice. The rationale, there's 3 reasons people can have a high PSA. Let's say they say you're low risk, but your PSA is 12. Well, you're intermediate risk by historical standards if your PSA is over 10. So does that mean we're being irresponsible in allowing that person to stay on active surveillance? Well, I think you have to scrutinize these individuals closely. And the 3 reasons that they can have a high PSA without necessarily being at increased danger of metastasis is 1, low-grade inflammation or prostatitis, 2, an enlarged prostate, 3, a low-grade cancer that makes a lot of PSA. So even though it makes a lot of PSA, doesn't mean that it's necessarily going to metastasize. So we're using PSMA PET scans as a tiebreaker in these people where we say, we're just so nervous about the PSA being up, we better just treat you to be safe. We get a PSMA PET scan, generally is covered by insurance because they have this is where having that low-grade diagnosis helps you. So insurance can, oh, he has cancer, we'll pay for the PSMA PET scan and confirm 2 things. 1, that there's no spots anywhere else. Of course, that would be the most important thing. But also that there's not another undiagnosed, heretofore unknown spot in some other part of the prostate that could be higher grade. Yeah. So it takes some of the pressure off us in this relatively common situation where men have low-grade disease by biopsy, but their PSA is running higher and makes everyone a little uncomfortable.
Yeah, and there are these cases out there, right? You see them. That's the MRI is saying, hey, everything seems to be fine. PSA is still going. Hey, your PSA density is changing. It's not 0.15 anymore. It's 0.20. It's 0.25. Well, that's tough. We'll just do another MRI. And I'm thinking, wait, why aren't they advocating for a PET CT here to be the tiebreaker at least, just to give them the peace of mind? It's so interesting you brought that up because that was going to be one of my questions, that why don't they use that as the tiebreaker more often?
Yep. Well, we use it all the time. And there's another interesting situation. We know that the men would have the high Gleason scores, the 8s, 9s, and 10s, that probably at least half of them also will never metastasize. It's never talked about because no one ever watches them. Because if there's a 50% chance something's going to metastasize in the next 10 years, are you going to sit around and watch it? Absolutely not. You're going to treat it because you can't take that level of risk. But I have had so many patients who've decided to simply watch their high-grade prostate cancer against all my advice, who have, after 10, 15 years, never metastasized. And this came home even more strongly when these PSMA PET scans show that they've been on the right track, has actually saved them unnecessary surgery or unnecessary radiation. So where am I going with this? Well, the point is that as we get older, let's say you're diagnosed with a Gleason 4+3 or a 4+4, and you're 78 years old. And we know that average survival of a 78-year-old is about 10 years. And you have a PSMA PET scan that shows you have no metastasis. Well, that individual's already had cancer for a number of years up to the time of diagnosis. The PET scan confirms, as of yet, no metastasis. Doesn't that argue that this particular Gleason 8 in that particular individual has a lower metastatic potential than just any old Gleason 8 that comes through the door? Sure it does. And what if we were to say, we'll monitor this and get a PET scan every 18 to 24 months, and if nothing spreads, we'll forego treatment. Some of these men are still sexually active in their late 70s. So that sounds a little bit cavalier, but we're also learning from these PET scans with the metastatic disease diagnosed by a PSMA PET scan is not the same as metastatic disease diagnosed by a traditional bone scan or a CAT scan. What's the difference? With the old traditional scans, you needed a chunk of cancer a ½ inch wide to pick it up. And almost always there would be other smaller spots all over the body. PSMA PET scans were detecting things at 2 to 3 millimeters. And since we radiate a lot of these and sterilize them, in some cases, these men are getting cured. Yeah. So this idea of the sharp demarcation between no metastasis and metastasis, which has always been the watershed event in all cancers, happy, simple, easy to treat, no metastasis, deadly, horrible metastatic disease. Now, in prostate cancer with PSMA PET scans and the sort of slow evolving nature of prostate cancer, that distinction is being blurred. And with regular PSMA PET scans, we're going to find some early metastatic disease that we can still cure. Yeah. So this idea of watching some of these older men with who don't have ideal Gleason scores is on the table now as a consideration.
Your point of that is a really good point, because what you're essentially saying is that now with PSMA scans, you can pick up the stuff that whispers, whereas with the other scans, we were picking up the stuff that already was shouting.
Yep.
And that changes the game, right? And so that's why you have all these patients. And I talked to all these other practitioners who have a whole bunch of oligometastatic disease patients. They got one little spot, they treat it. PSA goes undetectable for years. They don't have to take any other therapy but that type of treatment. That's a total game changer. Hey, those are 2 words I just made up. Game changer. It's not like that's not overused, but I think that's a really good point. Now I want to bring up another point.
Well, let's expand on that a little bit more, because I think that's the next. We've talked about these different scenarios. So the think about how revolutionary what you just said is. In the past, if we ever found a metastatic lesion, it was considered unorthodox to radiate it because there's so many spots. But some of us, myself being one of them, say, what do we got to lose? Let's radiate it. Let's give them hormones. Let's give them chemo. Maybe we can get rid of the smaller spots with all these other systemic therapies. That was the standard approach in my practice for 25 years. Yeah. And it helped some people. Now in 2024, with these PET scans picking up these early spots, our standard practice, I'm not saying universal practice, but our standard practice is, let's just radiate the spot and see if the PSA goes back to 0 on its own. Well, let's not mask it with hormone treatment. Let's find out if we hit the spot, and if that's the only spot. If the PSA doesn't go all the way down, let's get another PET scan and see where this other offending spot, let's radiate that spot. The quality of life is so much better not having to take hormone treatment. And the durability of these responses you already alluded to, surprisingly good durability.
Yeah, I mean, shocking. When it hits, it hits. And sometimes they're just repeated, and they can get a good, so
they used to call it whack-a-mole because the moles always kept coming. But we can't use that terminology anymore because in many, not all, but in many cases, they don't keep coming.
So we just went through a whole bunch of scenarios where MRI is great, but sometimes a PSMA's got to step in and tell you what's really going on, right? Now I'm going to reverse it on you, because I don't think this also gets enough attention, which also came up in the Q&A. And Raymond made me feel smart because he said that's a situation that comes up, but we always take care of it. God, it's amazing how many times you use the word PET MRI. I mean, as if it was one word, right? I mean, just PET MRI, just making sure you have access to both possible options. And so the other scenario is with all these PSMA scans, and the radio tracer is eliminated. And I had this on a sign. I can't find it because I got so many signs, I'm losing my mind. So with all these new PSMA tracers, these radio tracers, a lot of them get eliminated through the bladder. And then you see what's called a halo artifact. So the bladder lights up. So anything near the bladder can kind of be smudged out. In other words, something happening near the bladder, which the prostate's right there, there could be a lesion there or a cancer there that gets missed because of the glow of the PSMA. So every once in a while, and you should bring up a couple of these scenarios, there'll be nothing necessarily seen on the PSMA, but the PSA keeps going up. Then they do an MRI, and lo and behold, in the area where that glow occurred, this halo effect, they spot a lesion and they see where the disease actually is. So can you talk about that for a second? We first talked about how PSMA can complement MRI. Now, can you just mention how often in your practice MRI complements the PSMA?
Sure. What you're talking about, of course, where this comes up most frequently are the men who've had a previous operation, surgical removal of their prostate.
Yes.
PSA starts creeping up, and where is the cancer? And that's very common, not universal, of course, but the cancer can show up very close to where the prostate used to be and be obscured by the PSMA tracer that's being excreted through the urinary tract. I have to confess that I didn't come to our talk today as prepared as I should be, because I believe there's a new tracer out that isn't excreted through the urinary tract that addresses this issue. And we should find them and get them as a sponsor for our next meeting. But for the traditional, there's traditionally been two competing companies that do PSMA, and they both had issues with uptake near the bladder area.
Yes.
So this issue, of course, is important, and MRI can be a substitute. The difference between PSMA and MRI, which probably is apparent to most people, but so important for us to reemphasize, PSMA only lights up with prostate cancer, whereas if you talk about most scans, MRIs, CAT scans, bone scans, all these things, they light up because there's a shadow there, and the pattern of shadows can be interpreted fairly confidently to probably be cancer. But a PSMA PET scan essentially only lights up if it is prostate cancer, which is a powerful new realm for us in confidence. And that's why earlier in the talk, this conversation that we've had, we talked about substituting a PET scan for a biopsy, even, because that used to be the only way you could be 100% sure that it really was cancer.
Yeah.
So MRIs are more precise and give better resolution in the area of the prostate than a PET scan does. Although the PET scan gives you some disease-specific information, it doesn't give you the refined, fine detail that an MRI can offer. And so mixing them together, as you pointed out, PSMA MRIs in conjunction give you even more precision and confidence as to what you're looking at.
Yeah, we were talking about MRIs give a great look at seminal vesicle invasion, whether or not it's happened there, extraprostatic extension. So that clearly has its own little advantages. The PSMA companies right now are going after each other on who excretes less. So there's this is called hybrid PSMA. This Posluma says, well, we have less excretion through the bladder. The implication is, well, maybe there'll be less halo effect. So we'll have to see how that all plays out. Because again, sort of head-to-head trials with some of these companies don't happen as much. But it's something to ask about. It's something about the halo effects and the false positives and the false negatives and the catches of PSMA, which I thought we did a good job during Q&A going through with Raymond. I mean, they're there, and as long as you know what they are, you have other options in case you're one of those ambiguous findings, right? We have second opinion readings that you mentioned. We got an MRI. You have an MRI as a backup. So if you're caught in one of these middle ground areas where people don't know, there's other places to turn. Great discussion. All right.
Let's give a shout out to our friends at the Mayo Clinic, Dr. Kwon. I love how he opened it up with that guy's got a way with words. Do-it-yourself combat manual. The idea of encouraging patients to take responsibility for understanding their situation. It happens commonly in the type of patients that listen to PCRI videos. They become very sophisticated, very knowledgeable. Not that we're the only source, but they're out there doing their research, and they come to the doctor meeting prepared with some really profound and sensible, relevant questions, and they discover the doctor's sometimes even unaware of the technology they're talking about. And I want to take that as a good thing, because I don't think there's any other way to get state-of-the-art care these days. You have to do it yourself. To just rely on a general doctor. A urologist is treating kidney cancer, and he's treating testicular cancer, and he's treating bladder cancer, and he's going into the operating room and removing body parts. And then he's studying a little prostate cancer on the side. Your radiation therapist is treating breast, colon, lung, all these different complex diseases, and the information is exploding so quickly. People that you patients can become specialized enough to speak on an even level with these, even with the top doctors. And I think it's necessary, considering quality of life is such a prominent aspect of selecting treatment. Don't let someone tell you what your quality of life should be. You need to decide what your goals are.
Dr. Kwon always calls me in these random hours and goes, you know what, I hear about this, and that's fiction, and this is fact. And that's how it all came together at the end. We started talking about, why don't you just answer some of this fact or fiction stuff? And so, as a reminder, some of the things that we went through, and this kind of goes to what you were just saying. If I ask my doctor for a second opinion, is he going to be offended in the medical team? And that comes up a lot. And he said,
Yep.
yeah, I deal with that a lot. So I don't know if you want to comment on that, or the idea that stage 4 cancer is a problem, when in some cases it might be something that can actually be handled. So I don't know if you want
let's address the second one first.
Okay.
Because that was on my list to cover. I love how he formulated this for this idea of different types of stage 4. I think
Yes.
that is so important for patients to understand. Most cancers, because they have relative, let's talk about pancreas cancers or lung cancers. When they're stage 4, there's things they can do now, thank God, that we didn't have 15 years ago. But it's only a minority of people that can really do well when they have stage 4. The majority of men with stage 4 prostate cancer do well. The majority. There are patients with what he called diffuse disease that are going to struggle more. But you can even have diffuse disease and do well. So this idea of stage 4 is like the end of the line is a terrible misrepresentation. And I love how he broke it down into focal, zonal, diffuse.
Yeah, that was good.
Kind of the same idea with the minnows and sharks, which was this dichotomy between the harmless and the consequential. And then Dr. Kwon's injection is even a little more detailed in the idea of 4 categories, even after you're advanced, even after you're proven to have metastatic disease.
Yeah. What did you think? Well, I don't know if you wanted to talk more about that. I think the other thing when we kind of got philosophical was on insurance company denials and not being scared to appeal. And so in talking with Alex and the team, it's going to be a priority to make patients stronger at appealing and giving some examples. And then I thought of the example, because there's a couple different types of appeal. There's appealing to the insurance company because they said no, right? That's one type of appeal. But actually, I do think you're a pretty good expert at a different type of appeal, which I want you to comment on. And we haven't, now to remind the audience, we don't discuss any of this beforehand. So I'm about to throw him, I don't think a curveball, but a softball. There's another type of appeal that people don't realize. There's a medication, and it's available if you ask for it with your doctor, but theoretically it's not available. I know this has happened with some immune therapies before we had certain types of testing. So can you talk about the second type of appeal to not insurance companies, but to pharmaceutical companies to get a drug that the patient thinks is not accessible at this point?
So you're talking about compassionate use programs, which are pretty common in these pharmaceutical companies that make these very expensive drugs that normal people would otherwise be way out of. We're talking about medicines that could cost $5,000 to $10,000 a month.
Yes.
And this comes up in in a situation where people undergo the somatic testing, and a DNA abnormality is detected that is commonly observed in another cancer type besides prostate cancer. So let's say it's a DNA abnormality or a mutation that occurs in lung cancer patients, for which there is a specific medicine approved. In prostate cancer, we have these PARP inhibitors for the BRCA mutation, and people have a high likelihood of responding well to PARP inhibitors if there is a BRCA mutation on somatic testing. So, but what if you do somatic testing and it shows some other mutation, just as common in lung cancer as BRCA is in prostate, and they're treating those lung cancer patients with a specific pill, just like we're treating BRCA and prostate cancer with a specific pill, so-called PARP inhibitors. And doesn't it make sense that that pill that's working in men with a certain mutation in lung cancer might not work in that prostate cancer patient who has that same mutation? Can that happen? Yes, it does happen, and it's picked up in people that have genetic testing.
Yeah.
So, so you say what the problem is that these pills can be very expensive, but it's an off-label application of the medication. The insurance company is saying, nope, that's only for lung cancer. You can't get that covered. Approaching the manufacturer, the insurance company, the pharmaceutical company that is making the pill, commonly patients will get a free medicine from these pharmaceutical companies.
It's incredible. And people have to remember when they get liquid biopsies from Scholz or other clinics, they should get a copy of it, because the companies have become so good. Garden 360 Foundation, they're so good now in their analysis, is that when you have a mutation, it will say within indication if you have it and outside of indication. So if you have a prostate liquid biopsy, it will show you what drugs you might qualify in prostate cancer. And then outside of prostate cancer, off-label, it also gives that information in the report, and has for a very long time.
Yep.
I love it. Anything else you want to talk about? We only have 10 minutes left. Anything else you want to talk about?
There's some patient questions on Dr. Kwon. Let's see, he talked a little bit about, he called it follow-up. You know,
Yes.
I got to come up with a catchy phrase. So we'll use his follow-up. What I think he means by follow-up in patients that have metastatic disease is, let's say you're on Taxotere and your PSA is going down and everyone's rejoicing because these individuals often are resistant to all the hormone medicines, and it looks like a frightening prospect. And PSA's dropped from 50 to 20 to 5 from Taxotere infusions, and everyone's rejoicing. But we all know that Taxotere can't be used indefinitely. And what is your backup plan? So when things are going well in men with metastatic disease that are taking systemic therapy as for hormone-resistant disease, an area that Dr. Kwon sees a lot of, these patients should always be formulating Plan B. You say, well, don't the doctors do that? They're busy. They tend to be reactionary, and PSA starts going up, and, well, this was working before. Let's try it a little longer, maybe something good. When things start to change, they can change quickly. So this is a different mindset than our early stage patients, where we're saying, slow down, take your time. In men with hormone resistant, more advanced disease, that's the last thing. You never want to slow down, take your time. You want to be agile. And if it looks like, and of course, PET scans also can give you an earlier read. And this is something Dr. Kwon's been beating the drum on for a long time. Not only a uptick in PSA, but a progression on one of the scans. He does choline scans, PET scans, FDG scans, Axon PET scans. And to react to this information in a timely fashion is something that he wanted to emphasize. And I'd call it always having a backup plan in place, ready to go at the first sign that the cancer is starting to, let's say you've been on Taxotere and your PSA is coming down and it's starting to stabilize. The general feeling in the industry is, well, maybe give 1 or 2 more Taxotere treatments, hold it stable, but then move to something else. Don't just keep going internally. You can always come back to the Taxotere later, but why not try something fresh and continue to keep the enemy on the run? Or it's more like fighting a fire in these advanced patients, and just having a few burning embers is a lot better than a big flame.
Yeah.
But we all know how embers can turn around quickly and reestablish the flame quickly if we don't keep the pressure on.
Yeah, no, he has some really great points. That's how I was kind of enjoyed the fact that he didn't have that many slides this time. It's just, let's go off script a little bit. Let's really figure out what's going on in that in the gray matter there. And it's interesting how he presents things. I'll tell you a thing that still rings true in my head from a few years ago. I mean, comment on it or not. You know, we talk about these new PSMA scans. We talk, or the ones, you know, gallium got approved, Polarify, Posluma, you can pronounce it any way you want. But his argument is, look, first of all, just being able to have access to them is what I get excited about, not which one's necessarily better. I just want someone that's competent, that can read a scan, and whether it's choline or fluciclovine, Axiom, just having access to them is the point. It's not so much why are we arguing which one's better or worse. And it's those the kind of little moments where he kind of shakes me out of my emotions, right? And I just love those moments. Anyway, I have to throw that in.
So Dr. Kwon has really built a name for himself in handling these men with hormone-resistant advanced disease, some of whom have been told there's no hope, nothing you can do. And then lo and behold, he has some ideas that really make a difference. And what are we talking about? We're talking about men that have had Taxotere chemotherapy, probably Jevtana, which is a cousin. They've had Pluvicto, and they may have benefited from these things for extended periods of time, but now their disease is progressing again. And some doctors are talking about switching Xtandi to Zytiga to Nubeqa with relatively low yield. Others are talking about giving high doses of testosterone, again, with kind of low yield and sometimes some danger associated with these things. The natural thing that comes up next is to knock on the door of academia and ask them, what is coming? Can you get me on a clinical trial of a new drug that is going to be the next big, the next big Pluvicto? And Dr. Moyad, you're in academia. You've been through this with many patients.
Yeah.
What do you think is the best way to navigate this difficult area where we know the academics have all kinds of trials and they need patients? They're not necessarily looking to match you to the best treatment. They're looking to match someone to their trial. And people can get sidetracked into medicines that may not be very likely to help. Have you got any advice for us in terms of how to take advantage of the new stuff without getting hurt?
I always kind of, if you want to get really philosophical here, you know, I got to have a little sip of my green tea. It always makes me philosophical. Notice the advertisement. I always thought that life was about probability. What does that mean? I hang out with you guys because I like you. I'd rather hang out with a lot of you folks than other people. So the probability is if I hang out with you in the PCRI, I learned something, I can pass it on. When I got married, it was about probability. I was convinced that the person I would find, this would be a lifelong bond, and it has been. Probability also happens when it goes to the emergency room. The high probability gets the attention, right? We do what's called triage. We get more education if we want to, because probability says that's going to take us somewhere we couldn't have gone otherwise, for example, right? That's probability. We put on our seatbelts. Probability doesn't guarantee that I'll survive a car wreck, but you know what? It increases the chances I'll survive a car wreck. Why did we ever think that medicine would be different than probability? So when I think of clinical trials, or I think of medicine, what are the high probable clinical trials that looks like there might be success? So if you go down the line with all the drugs that you've been working with in your career, there was that gut instinct. There was, first of all, a phase 3 trial. This had reached the point where it was at the last trial. Now, if this trial is positive, it's going to get FDA approved. So you want to look for trials that ideally not only fit you, but are in the last phases of testing. If they just pass this one other probable marker, then they will be FDA approved. Think about it going back to early 2000. That was the deal with Taxotere and chemotherapy. You were excited about it. Then there was a phase 3 trial, and lo and behold, it got FDA approved. Jevtana became that way. We were just talking off camera about abiraterone, Zytiga. There was always this thought, they're in a phase 3 trial. I'm feeling really good about the phase 1 and 2 data. I'm feeling very good about a patient signing up for a clinical trial that's phase 3 that has a high probability of winning. Before Pluvicto was approved, You were sending people to Germany and through around the world because you had such a good feeling that it was going to get approved. So there was high probability in your brain that there was going to be success with the agent. And that's the type of thinking that I wish more people would get involved with when they're picking a clinical trial. So now comes along actinium, and overseas you're seeing success even when Pluvicto is not working. It doesn't mean actinium is going to make it. It just means it's getting to the point where if it does one more trial here in a phase 3 success, it will be approved. So I think before people pick their clinical trial they're going to go into, they just got to think about the word probability. What is the highest likelihood in a phase 3 trial of being successful? And I'm always looking around for these kind of moments, right? So that's why actinium comes up really high. I just picked off a meeting from an article about cabozantinib. Remember that drug? We used to talk about it, plus Tecentriq, in immune therapy that's being used in a phase 3 for patients. Well, they're showing some activity there. So I don't want to belabor the point, but think about it like life. You want to pick, ideally, if you can, a phase 3 trial where a diverse group of people with knowledge are feeling really good that it's going to clear that hurdle for success. And that is a little nugget that has served me quite well when people say, what's a good clinical trial? I think too many people say, is there a clinical trial? That's not enough. The question should be, what's a high probability good clinical trial that I can join that has a great chance of getting FDA approval? And then you ask the particular questions of, it's always important to know about crossover. What's the other group going to get? And if this drug is showing success and I don't get it up front, can I cross over and get that drug? Which today, now, most of the time is yes. So a short, semi-long answer to a very important question. We could do an entire lecture series on it, but that's how I get excited. When I'm seeing the words phase 3, I know there's been success in phase 1 or 2. I'm hearing about people going to different clinics around the world because prostate cancer is now a global disease in terms of treatment and clinical trials. Many of our clinical trials are international. You're hearing about success, and then it's like going to Vegas and you're betting on a hand that has a high probability of winning versus just a hand just playing the game. So if I put a number on the roulette wheel, if I just pick 14, my chances of success are very low, right? If I end up putting chips on about 20 other different numbers, my chance of winning goes up because I'm increasing the probability of winning. And this applies to clinical trials. So please have that kind of discussion with your medical team and second opinions. And even looking at, I still tell patients to look at the ASCO annual meeting, for example, the big meeting in June. See what clinical trials are in phase 3, see what's showing success. And these are the kind of thoughts. I think people should take as much time before they enter a clinical trial into any other aspect of their life. They should do heavy, heavy analysis because there are millions of trials. But in my opinion, there's only a handful of them going on currently that may show enough success in the next 12 months that will give that drug FDA approval.
It's almost the same thing as the sharks and minnows.
Yes.
Remember, it was 15% of men catch prostate cancer and 15% of those have it spread. You're saying what we are dreading, the bad type of prostate cancer, thankfully, is far less common. And what you're saying is that the really good clinical trials, the one that you would put your dad on or your brother on, are much less common. So we have to be quite discerning because it's a big industry. And the doctors that are talking about these are quite charming and they really believe in the science and whatnot. But anytime you hear the word phase 1 or you're looking at something where it's a lot of speculation. Phase 2 is hopeful, but more speculation. And I'm not trying to say these trials are never to be used, but it's a much bigger gamble to be doing a phase 1 or phase 2 because the information just hasn't been researched for with a great enough depth.
That's right. If you look at the 100-yard dash and you see someone right before they break the tape on a frozen photo, you feel pretty comfortable they're going to cross the finish line. If you see someone as a frozen photo halfway down the 100-yard dash at let's say the 50-yard line, I'm feeling pretty good they're going to make it to the 100, but I don't have proof. They're not that close. If I have someone that's just at the starting line, I don't know if they're going to get a false start. They're going to break their ankle. Something's going to go wrong. You can tell me nothing from that picture at the starting line of who's going to finish the race.
Yeah.
So all I'm saying is what a phase 3 does is it shows you right before the finish line tape who the players are that may or may cross the finish line. It's showing you later in time. They've already gone the distance. Now they just got to go that little bit further to get approval. Those are the ones I get excited about. Those are the ones that I like to talk about. Those are the ones that I think are going to get FDA approval. And according to the system, that's the only way you get the FDA approval if you are toward the end of that finish line. So that's kind of what we're talking about today, right? And we can go through every FDA approved drug in our careers. And I can't name that many surprises. Many of them were phase 3. The phase 1 and 2 look good. We were feeling really good about it. People forget, and you should probably mention this because we take it for granted. People forget that you were recommending PET CTs 4 years before they were FDA approved. And what were we all thinking? What's the matter with this guy? Has he lost it? He's recommending an imaging test 4 or 5 years before it's approved. He's telling people to go into a clinical trial and get the imaging done at UCLA because you had a darn good feeling from experience that this thing was toward the finish line and was going to break the tape. And so there were people in your practice and other practices getting these imaging tests 4 and 5 years before they were actually approved. That's the empowerment of a clinical trial. That's the empowerment.
Yeah. And I think that this is an essential type of analysis that patients who are maybe they've started on some Taxotere, maybe they just started on some Pluvicto, and we're very grateful that the majority of these men are going to benefit with declining PSAs, improving scans, but we know it's not going to hold the fort forever. And that means that it's time to get knowledgeable and conversant in this clinical trials world because there is stuff coming along. You mentioned actinium. We're pretty excited about that as a agent that can take someone who has had Pluvicto and maybe even progressed on Pluvicto and see meaningful responses that are durable. So I think that's a good example of this. And being sophisticated and wise on how to navigate this complex world. I think that's an excellent summary. Thank you so much.
No, I appreciate you bringing it up because let me just tell you, I'm in the preventive medicine world. This is so much easier outside of cancer. And the reason it's so much easier is a drug is tested in phase 3 against really difficult patients in the cardiovascular world. So you know what you're going to get excited about to take yourself. I remember when the cholesterol lowering, the statin drugs were just trying to make their way and just get approved. But they were working in people that had the worst type of cholesterol and lowering the risk of heart attacks in people with familial hypercholesterolemia. So I'm going, wait a second. If it's helping those people, I'm going to jump in that clinical trial. Look what's happening now with the newer drugs, these what's called PCSK9 inhibitors. They're injectable drugs that lower your cholesterol by 50%, and you can give yourself the injection. These are game changers. But what they were doing in phase 3 is they were taking the people with the worst cholesterols and reducing them dramatically and reducing the risk of heart attacks and other cardiovascular events and reducing the risk of needing a cardiovascular procedure like a bypass, right? Or an angioplasty. I'm going to bet on that drug. It's so easy in cardiovascular medicine. I wish we would apply that same kind of logic in cancer. Like I'm going to show you, I'm going to look at the track record. This is a high probability of success. So I just love it how it's done in cardiovascular medicine. I'm going to give you a classic example, what I bring up when I do a lecture. There's a drug called bempedoic acid, Nexletol. It doesn't work like a statin works, but it works on the cholesterol pathway at an earlier point. Well, it just got approved this week for primary prevention. So meaning that all these people who can't tolerate statin drugs, which is a fair number, it's not a huge number, it's a small minority, but that minority shouts, this becomes an option now, and the price should drop. Now, it comes with its own catches, but the drug itself is taken as a prodrug, and then it turns into the active drug through liver metabolism, but it doesn't go into the muscle tissue and cause those same kind of issues. So for some people, this turns out to be a huge winner. Well, this was first tested in much higher risk patients. So you get more comfortable with it that eventually it's going to find itself out there. I'm not going to mention the fact that this has nothing to do with Michigan, but it's an Ann Arbor company. I have no involvement with the company. It's just a great story of people wanted to find an alternative pill to a cholesterol statin drug that people could take if they couldn't tolerate the statin. That's a beautiful example of how to look at it. Remember, you and I have had all these people watch us about Wegovy, and remember all these GLP-1 drugs, Zepbound, and weight loss, and helping people lose 10, 15, 20% of their body weight. And now it's all the talk, and everybody knows what these drugs are. And we did a video maybe a year and a half ago that everybody in the world has seen. And we said, wow, these are exciting drugs. I think they're going to last. Do you have any comment on that before I comment? Because they're still helping a lot of people, and they still look really good. And what changed this week is Medicare now says, you know what? For some people who are high risk for a cardiovascular event, we may cover it. So they've gone from, these insurance companies have gone from, I don't think so. Now it's showing a benefit for people that have had a cardiovascular event to reduce a second event from a trial called SELECT by 20%. And now the companies are going, well, wait a second here. And all this has been happening this week, which is kind of cool. Any comment about these drugs? You still excited?
Oh, well, it certainly changed my life. There were two things in a busy clinician's life. I'm seeing, a large number of patients every day. And your physician, if you're smoking, you should be your physician should talk to you about that. If you're overweight, your physician should talk to you about that. But historically, these things have been psychologically so difficult to impact that we just jump past them and talk about things we think we might be able to change. Well, ever since the Ozempic and Wegovy and these new medicines came out, it's almost routine to talk to people who are overweight about the possibility of addressing this successfully with medications. Yeah. And it's a very exciting thing. And it's so revolutionary. I would say at this point now in early 2024, it's becoming routine for us to talk about this, which is it was mind-boggling before that we would broach the topic of weight loss with a patient, because historically all you did was make people feel guilty. There were motivational people who devoted their whole lives to diet that could make an impact on these people and help them hold their hand through weight loss programs. Very, very difficult. I'm not an expert in that. I didn't have the resources and the time to do that. But now, with the possibility of just initiating an effective pharmaceutical and changing people's lives, I feel obligated to talk to all of my patients who are significantly overweight.
Good for you. One of my favorite comments, and it is good. I'm so glad we talked about it. One of my favorite comments in the PCRI later that I hear about in the conference is they say, boy, as a moderator, we can't tell what side you're on. You really seem to come at it from both sides. And I say, well, that's my job. So my job now is to tell you after a few years what the downside of these drugs have been so far that we've learned. And it's very interesting because I didn't know I would have this kind of list to work with. So let me tell you the Moyad 5 catches, which goes also into my area, lifestyle. And I think these are catches you can work with now when doing Wegovy and Zepbound. And let me remind people that it's going to be in the next year or two, they're going to have an oral agent that's probably going to work almost as well as the injectable. So for some people who want to take the oral agent. But here come the catches. Compliance has turned out to be a catch. In some of these new studies, they did a huge one of insurance records recently. They found out that up to 2/3 of patients in some areas of the country after a year said, nope, I'm done. Now, why were they done? It could have been cost, because we know cost is a clear catch. That's an understatement. I always said to you in our talks, it's an embarrassment how much these cost. So compliance has to be discussed up front. Non-responders. Now we're learning that there's a small fraction of people who take the medication at various doses and they just don't get the hit that the majority get. And so it may mean switching to another one. Who knows what it means, but it's something that's going to have to be tackled. The biggest surprise, I think, for me thus far is number 4, anesthesia. Now the anesthesiologists are saying at least a week before an elective procedure or some type of procedure, you need to stop it, because if food is still in your gastric area and you could regurgitate that during a surgery or during some type of procedure, an endoscopy, for example. That food could go down the windpipe, and then you could have a real problem. You're going to develop a type of pneumonia, an infection. So you have to always check with the anesthesiologist before any procedure, especially any type of surgical procedure, any elective procedure. Hey, when do you want me to stop this drug before I receive anesthesia? Number 5 has surprised me because it's in my category. And I'll tell you why it surprised me. People think somehow this is magic and lifestyle doesn't matter anymore. The biggest success on these drugs have been people who maintain somewhat of a healthy diet, lower calorie diet, and are still physically active. They're the ones who in general in the clinical trials have seen the biggest effects. So I just published a paper last year in a medical journal that got some attention. And I said, look, lifestyle matters more than ever before with these drugs because it complements the drug itself. And another way it complements is that any diet you're on, or when you lose a lot of weight, you also lose a lot of muscle mass. So in the clinical trials of most diets where people lose 10 to 20% of their weight, anywhere from 20 to 40% of that will actually be muscle tissue. So now the push is that not only to get an adequate amount of protein in your diet, but you have to do this with resistance activity so that actually what you're losing is more fat than muscle. So there are lifestyle tips around these medications. It's the same thing with androgen deprivation therapy. Look, I love androgen deprivation therapy because it's been around for 35 years for a reason. It's changed lives, but we also have to admit it can change your quality of life unless you head it off at the pass. And in order for a person to stay on these drugs and be compliant, you don't want them to be dealing with a ton of side effects. You want to prevent side effects. So one complaint that happens with androgen deprivation therapy is, look at me, essentially I've gained some fat and I seem to have lost my muscle mass. And we have to remind people, just like with Wegovy and these weight loss drugs, the way to maintain your muscle mass when you're on any of these medications is resistance exercise twice a week. In some clinical trials is enough. Other clinical trials, it's 3 times a week. The point is you're doing upper and lower body weightlifting type exercises 2 or 3 times a week for a very small period of time, which can help combat that muscle loss. Because think about it, Mark Scholz, if I'm going to lose 20 pounds, I want 15 to 18 of those pounds to be fat. I don't want it to be muscle, right? And that is a point that has to be getting out there more to patients on these weight loss drugs. And that has to get out more and people on androgen deprivation therapy because this is a massive problem, muscle loss. So I'll get off my high horse. I just wanted to mention that. I don't know if you have any other comments. I want to also bring up another piece of news from last time to make myself feel good. Are you ready for this?
I'm ready.
Okay, I just had to review this for the doctors. This was one of the largest meta-analyses of randomized controlled trials just published in the British Medical Journal 2024. They looked at 218 unique studies, over 14,000 participants. Now remember, this is randomized trials of exercise, all right? And here's what they have found. Effects appeared proportional to the intensity of exercise prescribed, which means the more you bet on yourself and the more you exercise and the greater the intensity, the bigger the payoff mentally. And we're stronger for group exercise. So socialized exercise was stronger than isolated exercise. Anyway, here it is. These forms of exercise can now be considered alongside psychotherapy and antidepressants as core treatments for depression. In other words, when they graphed the effect of exercise in randomized clinical trials, it was as good as getting therapy and some medications. Now, of course, I'm not saying you should skip your medications and skip your therapy. I'm just saying anyone that's taking an antidepressant or is in therapy that's not exercising, that's a problem. That's a problem because if you look at this new data, it complements conventional therapy so much that it could be the difference between a response to an antidepressive agent or not. That's how profound it is now from an analysis of clinical trials. Unbelievable. Anyway, sorry. I don't know if you wanted me to say anything.
It's funny that the invisible underlying mood that we face the world with is it's construed as not being a health problem. It's a mental problem. And what you're saying is that there are actual activities that can change that, just as there are other activities and treatment that we can treat prostate cancer with. And
That's right.
that is, of course, a challenging one, but there are ways to make it a little less challenging. You mentioned getting involved with a group, having some sort of accountability, getting some sort of supervision, these sorts of things that allow us to measure whether we're actually following through, because it's so easy for us to fool ourselves and to compromise, and there is a momentum factor to this whole thing as well. The starting up part is always 10 times harder than the sustaining part.
Yeah.
And so if people are able to get on a roll, they have to really value the fact that they're on that roll and that it's precious. If you go on a 2-week vacation somewhere and take a holiday from exercising, I've had so many patients that will take a 2-year holiday from exercising because they can't get back to it when they return from their trip. So the defending the success that people already have is just as important as it is for those that aren't doing it to get started.
So if this doesn't motivate you to exercise, nothing else will. This just shows you that every animal loves exercise. Every type of person loves exercise after they conduct the exercise. You always feel the best after a workout. You never regret a workout after it's done because you feel so darn good with the endorphin release. So I thought I would give you a surprise one here toward the end of the conference. He's going to show you everybody benefits from exercise. And this is on the beaches of Lake Michigan with my dog. And I'm going to show you what I mean here in a second. Okay, here's Olympic training with my dog on the beaches of Lake Michigan. Here he comes. You got to look carefully. You see the little dot? Here he goes. Here he goes. Here he goes, baby boy. He's a front runner, baby boy. Baby boy's a front runner, and baby boy's gonna win. Good boy, good boy, you good boy, you good boy, you good boy. If I'm gonna comment on it, you can't see a happier dog running a 200-yard sprint like that. I mean, it makes my dog happy. Everybody's happy. And I'm gonna leave you with one more thing in exercise, because you know this is my mantra. This is where I like to hang out. Last year when we did Q&A, I brought up the idea of this erase trial. It was done in Edmonton. And it was a randomized trial of active surveillance patients. And everybody got so excited about its first publication because it showed that men became more fit over 12 weeks doing an exercise protocol versus not. All right. It even showed some PSA changes that were favorable for active surveillance. And people got excited. And I just kept saying, wait till the real good stuff comes out. And it did in 2022 in the Journal of Urology, the erase randomized trial. Here's the conclusion of what they found in these patients who got together a couple times a week for 12 weeks versus a control group. A 12-week supervised high-intensity interval training program appeared to improve prostate cancer-specific anxiety, fear of cancer progression, hormone-type symptoms, stress, fatigue, these are all significant, by the way, and self-esteem in men with prostate cancer on active surveillance, published in the Journal of Urology. If that was a pill, everybody would lose their minds. They would be so excited about taking that pill. This was just exercise in prostate cancer patients and all the profound mental health benefits. I rest my case when it comes to that.
Thank you, Mark.
Can I tell you one more thing? Can I tell you one more thing? This comes near and dear to my heart. I hear these words probably more than you do from friends. I hear it from family. I hear it from people I've just dealt with through the years. And I just want to respond to this. And you had no idea I was going to bring this up. And when it comes to lifestyle, and this is the part that gets a little bit of a hit, and I want to respond to it. I often hear, whether it's in breast cancer, colon, it doesn't matter the situation. I often hear this quotation: I did all of these things you tell me to do, all of these healthy things, and I still got cancer, and I still got a bad cancer. I always hear that. And I always give the same answer. And this is the quote that I give because I believe it. I've been doing this since 1999 in medical journals, saying this is what I'm seeing in the data. Yes, I say, but I think it was delayed or actually less aggressive because of your lifestyle. See, a lot of people take care of themselves. They do everything I want them to do, and still something bad happens. And they immediately defer to, well, this didn't matter. And I'm going, that's not what we're seeing in the data. What we're seeing is you delayed a very bad diagnosis. You reduced the aggressiveness or if it hasn't progressed as far, had you otherwise just sat on a log and done nothing. So what we're seeing in the lifestyle data, and maybe it's just reducing the risk of cardiovascular events while you're going through prostate cancer therapy. What we're seeing still is a major payoff in the area of taking care of yourself. And rather than going to the cup is half empty, I truly believe that what we're seeing in the data is the cup is actually 95% full, that had you not taken care of yourself in this manner, the situation could be actually much worse than what you have it, even though I know you have a bad situation. I think that just has to be stressed more because we're seeing this in data. This week, I'm reviewing a paper of bad genetics. We call it lethal prostate cancer. So in these studies, they have all these people that died of lethal prostate cancer. They're going back now and they're looking at diet, they're looking at lifestyle, and they're finding that some of the heart healthiest people for 5, 10, 15 years up before their diagnosis, when they've continued to follow them, tended to have a higher probability of surviving prostate cancer. So the payoff, they're not being told what the potential payoff was for putting that investment in. Instead, they're being told, well, you did all this exercise, you took care of yourself, and stuff still happens. I'm going, no, but you got to pat yourself on the back because maybe this happened to you at 62 and it was going to happen to you at 38 instead. And that's what we're seeing in the genetics. And that's what I think should be sold more with lifestyle, that it's paying off in some category that we have to just look at it a different way based on the statistics that we're looking at it at. So I had to throw that in because I just hear this quote a lot. I understand the quote, but I also understand the data that you can benefit in a multitude of ways, but that has to be mentioned to you where you're benefiting. Look, I just throw this out to you. Look at all the people going through chemo, androgen deprivation therapy, abiraterone, all these things that could potentially, they have to be on them, and these are life-saving drugs, but they have to be on them. But if they're not taking care of themselves, the quality of life is so much worse. I have to have you comment on that one more time. That so many people call me and go, well, I heard you have this side effect, that side effect, this one. And I go, well, are we talking about the person who takes care of themselves? Or are we talking about the person who does not? Because there's a huge difference. So Dr. Scholz, will you please comment on the person who goes through all these advanced therapies and takes care of themselves better versus ones that don't think it's as important?
Yeah, I think when people are getting more informed now, they go online and they hear some of the horror stories about taking Lupron and having low testosterone, and they find it quite daunting. And it is a powerful treatment, and removing testosterone or even taking chemotherapy has to be respected for its potential side effects, there's no doubt. But I can't tell you how many times I've had patients who listen to my admonition. In our practice, we take out a little contract that they have to exercise 3 times a day with weights. And although very few patients have been willing to do that, they do get an idea that I'm serious when I put the fear of God in them, that if they're not exercising, they're going to be miserable while they're on the treatment. And if they will comply with this protocol and be diligent and consistent, that they're going to feel relatively normal. And the patients come back after being in the midst of this, who actually have been taking this, and often will tell me that this has been nowhere near as concerning as I thought it was, because many of these patients have done a lot of research in advance to find and are quite intimidated by the prospect of having loss of testosterone or taking a chemotherapy medicine. And it is like night and day. Before we discovered this, maybe 15 years ago, we would counsel patients because we believe in full upfront disclosure. We told our patients, and we didn't know that exercise could help back then, and we would tell them, we're really sorry, we have to give you this life-saving treatment, and it's going to make you feel like a limp dish rag. You're going to just really struggle, and it's going to be very unpleasant, but it will prolong your life. Therefore, we are advising that you proceed with therapy. And that was just being honest, full disclosure as to what they're getting into. And of course, the patients that embark upon treatment in 2024 and don't follow through with their exercise do indeed feel that way. It is like night and day. So glad you've emphasized that. It is one of the, I won't say one, it is the most important thing that we counsel people about when we're confronting someone that comes in with more advanced disease and is going to be embarking upon testosterone deprivation.
I went to a prostate meeting. It was a small gathering of experts, whatever that means. You know, it's a big ego term, but I think we all just call ourselves experts for the heck of it. And someone gave a talk on androgen deprivation side effects, all the possible side effects that you could experience from androgen deprivation therapy. So they listed them all there. And then they talked about all the solutions, right? All the solutions. And then clap, clap, clap. And I said, Moyad, don't get too wacky here. Don't get emotional. You generally just stay your ground. Don't show your position. I said, just be careful here. And I couldn't hold my mouth. I got up to the microphone and I said, bring that slide back up. I said, you've just mentioned 8 to 10 potential side effects. I said, what's the only intervention on there that you have listed of all the interventions that cover basically 99% of those side effects? Maybe not hot flashes, we're not so sure, but almost every single other one. I said, it's exercise. Exercise covers the majority of the side effects that you're talking about with pharmaceutical medications, and those are helpful. But don't you find it interesting that what covers almost every single one of those side effects that can help mitigate those somewhat, from cognitive, right, to possibly even bone loss, muscle loss, all of those, exercise is one of the solutions. So why am I not seeing a pharmaceutical commercial that says exercise for ADT? You know, you don't see that.
It's not the pharmaceutical, it's the physicians. Earlier today,
yes,
we talked about how my behavior changed when talking to patients about weight loss or stopping smoking. And to this day, I don't berate people about stopping smoking, although we have things like Wellbutrin that can help. But my whole approach changed when things like Ozempic and Wegovy came out, where we could have an intervention that's going to make a real difference without having to undergo a giant psychological shift, which is a very time-consuming and difficult prospect. And this is the way most physicians see talking to their patients about exercise. You and I have crossed over to the other side because we realize it's a non-negotiable. Right. If these patients don't exercise, they're going to be in serious danger. And therefore, we are ethically obligated. I don't think most of the medical world or the physicians out there understand how dramatically powerful fitness is in patients who are going through androgen deprivation or radiation or chemotherapy. It makes a giant difference, and it's been well established in clinical trials. But I don't think it's just come home to the day-to-day practitioners on the front lines who are so busy and they have to know how to give different complex medicines. And the idea of figuring out a style, a communication style that's going to take some time out of their day with these patients to motivate them to change their lifestyle. It's if I hadn't lived with the misery of hormone-deprived patients for probably a decade before we figured out and it sort of surfaced in the field that this is an amazing breakthrough, fitness compensates for the deleterious effects of testosterone deprivation.
Yeah, and I want to remind people that we are cars. I'll say it again, we're cars, and with rechargeable batteries. You know, when we sleep, it gets recharged, right? And so we're driving around, and when you hit 50, 60, 70, if you have a car in your garage that's 50, 60, 70, it's no longer called a car, it's called an antique. That's fine. We're getting older, we're rusting, right? And the idea is you have to realize that as we get older and things rust and more things can go wrong, we have to start taking care of that car more and more. So even not just on androgen deprivation, people don't realize that once you hit 40 and 50, there's a actual metabolic physiologic change where the human body just gets older. It's not capable of doing what it used to do. So what happens is adipose tissue begins to infiltrate. It begins to infiltrate bone marrow. It begins to go into pericardial tissue like the heart. It begins to go into the muscle. And unless you subscribe to the use it or lose it phenomenon, it will continue to do that. So they say by the time you hit 70, if you don't do much, you lose 40 to 50% of muscle mass. That's true, because once you go into entropy where you're not doing something, then the machinery, the car, starts to fall apart. So even for anybody who's not undergoing all these drugs, it could be someone who's just doing perfectly fine. The body begins to age and it starts to accelerate unless you do something that's anti-aging. And unfortunately, the anti-aging phenomenon has been sold as a lot of these different elixirs, when in reality, it's about using it or lose it. It's about aerobic activity being combined with resistance activity. And then that should become mandatory. And so what we're reviewing now are papers of people in their 80s and 60s who are now doing resistance activity with aerobic activity 3 times a week. And what's stunning is how quickly they're able to gain more strength, balance, coordination, and muscle mass, and how they become so much more mentally and heart healthy. It's stunning. What's also stunning in these clinical trials is how at the ages of 60, 70, 80, 90, when you take a couple weeks off, boom, the body loves to go back toward being filled with adipose tissue, and physiologically you run into trouble. So taking too much time off becomes far more risky with aging than it did when you were 21, of course, right? And these kind of things have to be taught. I'm going to leave you on this topic with a big ego boost, so you're not going to get your head out the back door. I can't tell you, and I shouldn't even admit this, I can't tell you how many times I've gotten somebody in person or on the phone, and they say, well, I'm doing all this, and I just love my exercise routine, and I'm doing much better with chemo, and I'm doing much better, for example, with hormone therapy. I mean, everything is just a lot better, and oh my gosh. And I'm sitting back going, yeah, it's okay. You don't have to buy me a car. I know what I preach. And they go, you know what did it? And I'll go, no, what did it? And I'm going, here it comes. The love for Mark Moyad. They're going, I was watching a video, for example, and Alex and Dr. Scholz were on it, and they were talking about exercise. And I thought to myself, well, there's an oncologist who sees only prostate cancer. So if he prescribes exercise, I'm definitely in. That was a life changer. And I'm going, wait a second, it wasn't me. Well, take your ego out of it, Moyad. And I'm going, that's your point. Your point is when someone is day to day in the trenches and says, this makes a difference, it screams to the patients. It screams. I can't tell you how many times in the past several years someone told me that when Scholz emphasized it on a video, I was convinced he must be seeing something because he just sees prostate cancer. And I go,
well, this has been shown in studies too. I don't know if it's motivating for our fellow physicians, but the studies, and you probably know the literature, show that if, I was talking about being intimidated by the time and my lack of skill, say, in talking with someone about ceasing tobacco use, and that we'll just live with this. And but studies, the limited number that I've reviewed, show that physicians can have a big impact in motivating people to change their behavior, even with tobacco abuse, which is so addicting.
yeah.
So thank you for that kind comment. And I want to take just a second too, Mark, to thank you for making another one of these conferences just a delightful success. Thank you for the speakers that you bring to the table and drawing the best out of them, and for helping this information get into a digestible form for our patients, who's really our audience. I know that there are physicians and other caregivers that pursue prostate cancer and men's health understanding through the PCRI, but it's primarily the patients, the ones that Dr. Kwon says are the do-it-yourself patients that are looking for their own combat manual. So I just so appreciate that you've carried us through this again. I know it's been a lot of hours and a lot of preparation, but thank you.
I appreciate it. Of course, you know how much I appreciate you and the whole team out there. And people always say to me, do you watch the videos? I told Alex this morning. I said, I don't watch the videos after they're done, because it's like telling someone who prepares all their life for a Super Bowl. And, I just want to be ready for the Super Bowl. And then after the Super Bowl is done, I've had it with the Super Bowl, because there's so much prep that goes on in here. But the one comment, the one place I appreciate is that people always ask me too, well, why don't we talk even more about diet and lifestyle? So finally, I decided when we sat down with Alex and the team, we said, we're going to create a series of diet videos and release them every couple of weeks. And it's going to start in April and May, that my wife and I did, because my wife's such a great cook and she has great nutrition knowledge too. And we're just going to cover topics in the area of lifestyle, not to try to sell you a specific lifestyle or a specific diet. What makes me half wacky is when people say, this is the only diet you can do. This is the only thing that has data. When we know that that's not true. Lots of different methods have data. So what we've already done is put 5 in the hopper, and we're going to do another 5. So over the next 6 months, every few weeks, you're going to see a release on a certain topic. So we're going to talk about omega-3s and salmon and fish in the first topic, and not only how to prepare it, but how to look at it nutritionally, and also how to look at it from a medical standpoint. And they're not there to say, this is what you have to do. It's just to do and give you a foundation of what's going on in the lifestyle world. So for those of you who leave this conference going, Moyad didn't talk enough about lifestyle, he didn't talk enough about multivitamins and all these other things, we are going to cover that over the next few weeks, and we're going to make sure that gets its due, because we've had so many requests. And I promise you, by the end of this year, you're going to go, I'm sick of him talking about it. So I want to thank...
It's an unmet need. And I think the idea of providing professional state-of-the-art information without an underlying agenda, who gets motivated to do these sorts of things is someone's got a new pill or a new angle, and so they hire a charismatic guy like you to be their spokesperson. And there's this agenda that's undergirding these things, and you've been in this realm and have no affiliations with any of these companies, and can just bring your experience and your delightful persona and communication style to motivate us, because it's not only knowing what to do, it's being able to follow through and actually make the lifestyle changes that lead to these benefits. And the last thing I want to say is that you've got that common sense that you're not going to waste our time with stuff that has some technical, theoretical benefit in rats from 13 years ago. Practical, down-to-earth stuff that is something that you would do in your own life, that is what you feel is justifiable and beneficial, because there's cost or there's inconvenience that is associated with these lifestyle changes.
That's so true. And I appreciate that, because people still ask me, I get hounded by a lot of nutrition companies, supplement companies, come on, we'll pay you X. And I'm thinking, that's okay. Maybe earlier in my career, when I had to do it, people always step over the boundary in some way, but I'm just going to tell you what I believe now, which is, lifestyle changes change lives. That's become my mantra. Doesn't mean that you shouldn't embrace conventional medicine. I'll just give you a classic example. Alex showed me a bunch of questions for this meeting, and it's the same. We got a number of questions, for example, can I have an egg? It's a painful question for me to read. It's a painful question, because life is meant to be enjoyed. We can go into the environmental and all that stuff, but the question in and of itself, can I eat an egg? Is that okay? Well, we take people through the education. It may have a little more cholesterol, but it also has vitamin D. It also has these 2 carotenoids called lutein and zeaxanthin, which are good for your eyes, for example. And it tends to be low calorie overall, and the egg white is a decent source of protein. So can you have it? Well, yes, you can have it, but it also means that subjectively, if that's something you enjoy and that makes you happy, great. But you also want to combine any dietary change or what you think might be a sin with something that's objective. I find it interesting that in all of medicine, we use PSA, PSMAs. We talked about MRI. We talk about all these ways to gauge success, but we don't do this enough with diet. So the truth of the matter is, if you know all your basic numbers, you know your cholesterol, you know your blood sugar, you know your blood pressure, you know all the numbers that matter, your weight. If you're having a bunch of eggs during the week and then you go up for your follow-up exam and your cholesterol is suddenly through the roof, there's an indication, an objective parameter that maybe you need to dial it back. But there are plenty of people that have several a week and their cholesterol won't even budge. Part of this is based on genetics. And that's why I love the genetics talk, because we all have these polygenomic situations where some people, for example, are fast metabolizers of caffeine. Some are slow metabolizers. We're going to learn more about cholesterol. And some people can eat 5 eggs during the week and their cholesterol doesn't budge. Some people eat 2 or 3 and their cholesterol takes off. By working with your doctor and knowing your numbers, the answer to whether or not you can have several eggs during the week will come up and be answered for you individually. That's the point. But to look at the question as an all or nothing event is what the fallacy is. And I don't blame the patients. I blame the experts for telling people, oh my gosh, if you touch that one food once or twice a week, you're going to HE double toothpicks. It's not that simple. I wish it was that simple. It was that black and white. It's not. So for those of you people who love eggs, I'm not going to go into the environmental part. I'm just talking about straight. If you want to eat an egg and you're worried about it in terms of your heart and your prostate cancer, this is why you work with your physician to know your numbers. Plenty of you, including on cholesterol-lowering medications, will never see a change in your cholesterol. Some of you, and unfortunately, will see a change and will then know you have to dial it back. It's the same thing with sodium. Do you know how mad it makes me that my two brothers can eat as much sodium as possible and their blood pressure doesn't change? If I go over the recommended daily allowance of sodium, if I even go to 3,000 milligrams a day, my blood pressure shoots up. I get in trouble. I am clearly working with my doctor, one of those salt-sensitive individuals. So my sodium requirements are much less than the average person, but it's just what I was born with. That's the way it is. So what we're going to do in this diet series is we're going to give you the data and how to look at it in a way where you can individualize it. Does this work for me? Does this kind of food work for me? Because one thing that's mentioned is this compound of cell membranes. It's called choline. So, you know, in Mayo Clinic, they have that choline, right? PET CT. And some people are scared to get choline. But we forget choline's not just found in dairy and fish and meat. It's also found in cruciferous vegetables. I want you to eat your cruciferous vegetables. Of course I do. So again, our series is not about telling you you have to do something. It's giving you the tools whereby you can decide whether or not individually that works for you or not. And that's the essence of my teaching. And that
I think this is going to appeal to our the same folks that Dr. Kwon is appealing to and trying to encourage them to take responsibility and understand if the metabolism of these complex bodies that God has given us was that easy to understand, this would have all been worked out a long time ago.
That's right.
We'll certainly look forward to that. And thank you so much again for making this happen, Mark. We really, really appreciate it. And I want to mention as we close the our going back to actually meeting in person in September, the second weekend of September. This is a event that has been a storied centerpiece of the PCRI for almost 2 decades.
Yes.
And so we're looking forward to that happening at the Marriott Hotel in in the second weekend of September. And Dr. Moyad will be moderating, and we'll have a lineup of wonderful speakers. So thanks again, Mark, and hope you have a wonderful, wonderful Easter.
I can't wait to see you in the fall. Are we going to be in person? Now realize Michigan is national champions for 1 year. So do you think I'm going to make everybody nauseous around me by wearing all this gear at the conference? Of course I am. And just remember, had you gotten those 2 quiz questions right at the very beginning, you would have had dinner for free for life from me. But at least now you know the answer to the question. Who was the national champions this year? Michigan. Who did they beat? The University of Washington. I am now converting one of my best friends of all time, Dr. Mark Scholz, into a Michigan fan. Thank you, my friend. I can't wait to see you soon.
All right. Thanks again, Mark.
Thank you.